Good day, everyone joining us for Nurses in the Know with RNAO, Preventing and Addressing Abuse and Neglect of Older Adults. I want to welcome you all, the hundreds of you who have joined us from across Canada and indeed around the world. I'm Dr. Imogene Baynock, and I'm the Director of the International Affairs and Best Practice Guidelines Center here at RNAO, the host for your event today. Today, then, we have a wonderful group with us, and I want to just make note that we have Dr. Elizabeth Podniks and Dr. Samir Singh, both of whom were co-chairs of our expert panel that developed the guideline Preventing and Addressing Abuse and Neglect of Older Adults. In addition, we have Susan Story-McNeil, the RNAO nurse manager who shepherded this guideline throughout the processes and made sure that it reached publication and now, of course, dissemination. In addition, I want to thank Verity White, who worked closely with Susan on the guideline and as well has been really the force behind our webinar today. So thank you all. I'll move now to looking at just a brief highlight of the agenda. And we've gone through the overview and welcome. We will be talking very specifically about the guidelines, some background, what is abuse and neglect, the impact on individuals and society. I want to talk a little bit about why is this important now and how we can collaborate to address and prevent the problem. And then we will move into some very specific details about the guideline, how it was developed, highlights of the recommendations, and then moving very specifically into how can this be used by you, what difference will it make for you? And we'll look at implementation resources that are being developed and some strategies. Following that, we will have opportunity for your questions. Now I'm going to move to the next slide that is focused on RNAO. RNAO, the Professional Association of Registered Nurses in Ontario. RNAO is a strong, credible voice leading the nursing profession to influence and promote healthy public policy and clinical excellence. And as I say always when we talk about clinical excellence, the Best Practice Guidelines program is really a cornerstone, a signature program of RNAO, and the major means by which we are promoting clinical excellence. I'm now going to move to the next slide that is focused on the highlights of the Best Practice Guideline program. And you can see on that slide that we have 4 circles. The top circle really talks a lot about the guideline development process because RNAO at the BPG Center is focused on developing evidence-based best practice guidelines using a very rigorous 7-step process. And this process includes use of research associates. Housed at RNAO, we have a staff of 6 research associates and a team of managers and project coordinators under the leadership of Dr. Monique Lloyd, the Associate Director, to really focus on developing the soundest and most rigorous guidelines possible. Our guidelines are reviewed every 5 years and new additions are developed as new evidence is available. I'm moving over then counterclockwise to the next circle, which is talking about deployment and implementation. And of course, deployment starts with that wide dissemination, and that's what we're doing today, and also then various other ways that we support these guidelines moving into the heads, the hands, the hearts of nurses and other healthcare professionals. And you'll note with this guideline, it was interprofessional in nature, and national in nature, but we know it has international implications. I'll move along then to the other circle, which is talking about evaluation. And through this circle, we're really talking about how we monitor and measure the impact of guidelines in day-to-day use. Developing them is one thing, that's not enough. Implementing them is another thing, but even that's not enough. We have to see that they make a difference, and that they make a difference for those in our society, for the public, for nurses, for organizations, and for communities as a whole. So I do want to now introduce you to Dr. Elizabeth Podniks, who will talk next about abuse and neglect and give us some background about that. Elizabeth Podniks is a professor emeritus at Ryerson University. She is a champion, I must say a one-woman champion related to elder abuse and neglect. I had the very great privilege and pleasure of knowing Elizabeth almost 30 years ago when she first unearthed the notion that we needed to do something about elder abuse and neglect. It was an unknown, unheard of area before Elizabeth gave it voice. So I'm so pleased and proud to introduce Elizabeth Podniks and ask her to carry on with the remaining set of slides that focus on abuse and neglect. Go ahead, Elizabeth.
Thank you so much, Dr. Baynoff. I'm really thrilled to be here and wish you were here. I have been tasked to talk a little bit about definitions, and as we know, definitions continue to dominate research, discussion, and funding. The guide identifies definitions from WHO and NICE publications, and both of these refer to the expectation of trust in their definition. Other definitions omit the statement about trust, citing while there is usually an expectation of trust, not always. For instance, residents in nursing homes may have no reason to trust. In fact, they may be quite fearful. People view elder abuse through the lens of their own specialty, such as nursing, social work, medicine, etc. The late and legendary researcher, Dr. Rosalie Wolf, saw elder abuse as any form of harm to an older person. She argued that organizations should develop a definition based on their own needs and policies, and then proceed to intervene. One category of elder abuse recently in the news, which is on the slide, but it's not often discussed, and that is professional abuse. Juliet Clark was an elderly woman living in New York in a New York hospital. Following her death 2 years ago, the family filed a lawsuit against the hospital, doctors, and staff for having coerced her into making large donations to the hospital for various things such as renovations. They won the lawsuit. And the good news is that the Clark family is now funding financial abuse research. One of the nurses who received $35 million in the suit was asked if she thought that this was unusual, an unusual amount of money. She replied, no. The next slide is a little an illustration about theories and the fact that elder abuse is such a complex problem. The guide provides several theories to explain elder abuse. Scholars have for a long time been advocating that elder abuse and neglect should have its own theory. We have been borrowing from other theories, and all the professional articles are quoting up to 6-8 theories. And since the issue has been discovered, and it's now time for us to have our own theory. How can we teach and guide students if we don't have a conceptual framework? And so a goal out of this is to generate, which has been actually convened, an international committee on the development of a theory to guide elder abuse and neglect. And this hopefully will be reported on at the proposed Global Summit on Elder Abuse in June 2015, to mark the 10th anniversary of World Elder Abuse Awareness Day. In conclusion, I would first of all like to stress that that human rights is the cardinal element in looking at elder abuse. Elder abuse is a healthcare issue, it's a social issue, it's a justice issue. But if we don't have human rights, how can we access any of these other things? So we see the guide as an ongoing conversation. The RNAO is not presenting the guide as the definitive answer to any of the concepts that we've talked about in the guide. Rather, it is asking each of you on this webinar to ensure that there are changes made and that the guide is kept relevant and up to date. What is the impact on individuals and society? You're listed several titles of things that are of great concern and interest, but one of them is the fact that elder abuse can lead to increased nursing home placement. Some of you may remember when the initial intervention in elder abuse was to remove the person from the home, and this was very traumatic for everyone. Fortunately, we've moved away from that, but it still does exist, that the older abused person is taken away rather than the situation being adapted and the perpetrator removed. Also, deserving mention on this in this area are loneliness and social isolation. These two things have huge impact on both individuals and society, and are risk factors not only for the present but for the past in terms of intervention. Social isolation is a huge risk factor and must be dealt with accordingly. So I will now turn it over, and not before though thanking Dr. Greenspan, Dr. Bannock, Susan McNeil, and Verity White, and that fabulous research team that did all the data collection for the lit review, and also to our unbelievably committed committee who are really responsible for this guide, which we hope that you will continue to use and help us to update it so that it is not sitting on the shelf. Thank you.
Thank you so much, Elizabeth. Really appreciate your words, and also very exciting event to come in 2015, and I'm so grateful we have the guideline with your input. I want to now talk or move things to Dr. Samir Sinha, And as you can see from the slide, Dr. Sinha is Director of Geriatrics at Mount Sinai and the University Health Network Hospital. He's the expert lead of the Government of Ontario's senior strategy. Now, Dr. Sinha, as those of you who know him, have ever heard him speak, know he's a passionate and well-respected advocate for the needs of older adults. And he gave generously of his time and his knowledge to help us develop this guideline. So can you see, along with Elizabeth's expertise and visionary leadership and Dr. Samir Singh, we have a wonderful guideline. So let me turn it over to you now, Samir, to talk more about the importance and how we can collaborate to make a difference. Go ahead, please.
Thank you very much, Imogene. So greetings everyone as well, and it's great to be here today because again, this represents a lot of great work that's happened, not just over the past year, but going back many years with people like Elizabeth leading the way. So we talked a little bit already now about why this is an important issue in terms of what is elder abuse and what are the forms that we understand. So the question that we now ask is kind of why is this important now? Why do we develop a guideline? And the most important reason is that we are appreciating that it's more common than many of us think it is. I know recently at our hospital, for example, as we were rolling out our elder abuse policy and guidelines, I remember the leads of that were saying that there were some clinicians who were coming up and saying, does this even really happen? You know, people would actually abuse and neglect older adults. You know, most of us think that it's such a horrible thing, but why could it even take place? But really, it's more common than we often think it is. Prevalence studies say maybe around 4 to 10% of people are being actively abused in any given year. But we know as well that the prevalence and the risk of elder abuse can actually be significant, and upwards of 1 in 4 vulnerable older adults, or 1 in 4 older adults could be vulnerable to older abuse, elder abuse in particular. And especially those who are dependent on others for their care, those individuals with dementia, who have memory issues, those people who have significant physical limitations. We could see how sometimes they become incredibly dependent on those, on other people. And sometimes that makes them particularly more vulnerable to elder abuse in particular. So this is why it's an important issue, because it's actually quite common. It's more common than it should ever be, and we should never have any elder abuse happening. And we know that some populations are more vulnerable. And so the implications that this has are significant, because many of us know that the aging population, our population is going to double in size over the next 20 years, with those who are 65 and older going to double, and those who are 85 and older going to quadruple. We also know that there are societal shifts that are occurring as well. You know, the recent economic recession had put many individuals in specific situations where they may not have enough money on their own to help with their retirement issues and so on, so they may become more dependent on others. We sometimes have situations where children or other family members may be in financial situations where, therefore, they may actually take advantage of a vulnerable older adult that they know. So it's something that we're seeing more and more common. And we think that with the aging population, not only are we going to have more people who are potentially vulnerable and will actually experience elder abuse, but societal changes with people less likely to be living in intergenerational households or communities are going to make more people vulnerable and at risk to this. So as frontline care professionals, you know, we need to be abreast of this issue, and it's not just a nursing issue. It's an issue that all professionals at the front line should be aware of, and we need to know about this, especially so we can approach this issue in a well-balanced way. So the next slide really speaks about how we can collaborate to prevent and address the problem. As I was saying before, it's not just a nursing issue, and therefore, but we also know that because all of us get exposed to this, that often effective responses around cases of elder abuse and neglect require a collaborative effort and require also a commitment at multiple levels within an organization, but also across disciplines and sectors that we need to be involved with in particular. So let me elaborate on that a little bit. when we're actually seeing that if a nurse, for example, understands that one of her patients or his patients is experiencing abuse, the question is, where can they turn to support their patient to get better support? So how do we leverage the support of other team members, such as the social workers on the team, the therapists, the physicians, but also thinking about how do we actually involve people beyond healthcare. Sometimes we need to get folks from social services involved. Sometimes there are legal precedences and obligations that we have to be in mind of. Sometimes we need to get the police involved. The key is that elder abuse issues are never straightforward. They can often be quite complicated. And that's why having a team approach is really, really helpful. And that's really what the guidelines started to focus on when we said we need to really help our colleagues understand what they can do in practice in terms of practical ways to support themselves as well. And so the good thing was, as we started doing our review of the literature and starting to understand there are some innovative and collaborative approaches already occurring, but we don't see that there's a system-wide approach. What we do at Mount Sinai Hospital may be different than what happens at University Health Network, which may be very different to other hospitals around the province and around the country. And as well as different jurisdictions have different obligations on their professionals and different resources available. So how do we reconcile those differences and give us some guidelines so that we can start working together within our organizations and with others as well? So the next slide just talks a little bit about collaboration and the collaboration that we saw was necessary as Elizabeth and I took on the role of co-chairing this in partnership with the RNAO. And in particular, as we know that this is often an interprofessional effort, this is a cross-sectoral effort, we really felt that we need to have a group that represented a diversity of professions, but also areas of practice and also areas of work that occur. So, for example, we had professionals from nursing and the various areas of nursing in particular, but also medicine, social work, those with a law background, those interested in policy, patient advocacy, research and education. But we also want to make sure that we also have representation for people who work in rural and remote communities as well, because sometimes those areas are not as well resourced as others. So how could we create then a guideline that would actually extend across these settings so that any nurse or any professional anywhere in Canada and beyond could look at this and say, these are practical, evidence-based recommendations that can support me and my colleagues in our practices preventing and addressing abuse and neglect of older adults.
Thank you very much, Samir. And again, thanks to both you and Elizabeth for role modeling that collaborative approach, Elizabeth being a registered nurse and Samir a physician. I want to turn us now to really moving right into the guideline, and I want to introduce Susan McNeil. Susan is a nurse manager here at RNAO. She's a master's prepared nurse. She was the perfect person to lead this guideline. She heads up the work with our guidelines related to older persons. She has a passion for dignified quality care of older adults and indeed, I must say, of all persons. So without further ado, I'll turn things over to Susan, who in the next 20 minutes will really take us through the details of the guideline. Go ahead, Susan.
Thank you very much, Regine. So as Regine stated, I'll go into some of the nuts and bolts of the guideline. And as you know now, the title is focused on preventing and addressing abuse and neglect of older adults. And as the subtitle indicates, we are really looking at person-centered approaches. We're looking at, like Samir had said, collaborative approaches and looking at tackling this complex issue with a system-wide approach. Also, I would like to acknowledge the funding. We've been generously funded by the Government of Canada, the New Horizons for Seniors program, for this initiative. So the next slide, I'll give you a very brief overview of the process that we use to actually develop the guideline. And this is similar, this is the same as all of our RNAO guidelines. And it is a rigorous development process. So we hope that you will have confidence in the guideline. The first step is at the top to assemble the panel of experts, and You know that we did have a diverse panel on this guideline. The next thing that we do is a systematic literature review to sift through thousands of articles. And in this case, we had over 13,000 articles that we reviewed to find out what are the ones that are most relevant, up to date, and the highest quality. And with that sort of short list of research, we took that back to the expert panel, and we said, what do you think of this? And what should be the recommendations that we put in this guideline? And we state the recommendations and then discuss we provide a discussion of evidence to support that recommendation. And then every recommendation has a level of evidence assigned to it, so that you can determine to what degree what strength of evidence there is to support that. And you can find out more information, I believe it's on page 11 in the guideline. There are many iterations that we go through to develop the actual guideline. Once we're nearly done, we send it out to the stakeholders for review. And this guideline had tons of interest. We had over 60 people from across the country in diverse settings and practice areas who consulted on the guideline. They've reviewed it and told us what if they agreed or not and why, and if we missed anything. Then it goes for a final revision and some tweaking, and then we put it to publication, and then we'll look at it again in 5 years. So that's kind of, in essence, the guideline development process. So why did we develop this guideline in the first place? I'm talking about the purpose and scope. Really that there is, as Samir mentioned, variability in practice, and we really weren't, it's not very clear on what the best practices are, or those best practices are not widespread. So our purpose was to expand the awareness of this topic and let people know what the evidence-based recommendations are. And this guideline really is meant to be applicable across all healthcare sectors in the continuum of care in Canada, from public health to the ER to long-term care and everywhere in between. So it is, there are guidelines that are applicable for your setting. And just to keep in mind that this is not a how-to guide. This is a guideline of recommendations. We also, another point to make here is that we are focusing on all the main forms of abuse and neglect that could occur in a home setting or in a healthcare organization. So just an overview of the guideline, we have 10 practice recommendations. And for those of you who are on the line, these would be applicable to you if you are providing direct care on a day-to-day basis with older adults. So this guideline is not just for nurses, it's for nurses and other healthcare providers in the interprofessional team. So 10 practice recommendations. We have 4 education recommendations. So those of you who are educators or interested in quality improvement, or those of you who work in academic institutions and teach undergraduate students. And then we have 8 policy, organization, and system recommendations. And these are looking at broader supports that enable the other guidelines to be implemented. And so we have recommendations for managers, administrators, policy makers. But what is a bit unique is that we have recommendations for nursing, regulatory bodies, and also for governments. And what it is, it's recommended that an organization implement the recommendations in each of these areas to be most effective. What I'd also like to point your attention to is there are quite a few resources in the back of the guideline. So if you're a researcher, you might be interested in the research gaps. If you're looking at monitoring how well you're doing with this guideline, there are indicators for evaluation. But what you might, those of you who are in practice, you might find that the appendices are really useful. We're hoping they're really useful for you. There are practical tips like communication tips, tools, review of assessment tools, and some various other resources in the back. So take a look there and see what might be useful to you. So the next slide. Now I'll give you some highlights of key themes from the practice recommendations. So what is really important And this may seem obvious, but a therapeutic relationship is really fundamental when you are discussing and dealing with issues of abuse and neglect. These are highly sensitive issues. They're very difficult to talk about. There are many barriers and fears to admitting or disclosing abuse and neglect. So having a therapeutic relationship with an older adult and those involved with their care, such as family members, is very important. Similarly, privacy and confidentiality is really essential. So some information may be appropriate to share for the continuity of care, but what you need to do is make sure you are clear on what information you can share and what you should not share without getting permission from the older adult first. And if there are times when you must disclose information, even if you're asked not to, when you must. So, for example, if there's mandatory reporting, say a colleague was abusing an older adult, and someone said, "Well, please don't tell on them," you may. It's very likely that you must disclose that information. Another key component of the practice recommendations is to really be alert for the risk factors and the signs of abuse and neglect during all of your encounters with older adults and families and other healthcare providers. So to be on the alert, because you are really you're in a unique position, and you might be actually one of the only people who would be able to pick this up and maybe support your client or help put a stop to mistreatment. So we suggest that you pay attention to possible disclosures, the subtle disclosures of abuse and neglect, or watch for risk factors and signs. So the next slide is other practice recommendations. Talk about how to intervene when an older adult is either at risk for or actually experiencing abuse and neglect. So what is really important here is to identify the rights, and that may be the right to refuse intervention or the right to go back to a situation that you might think is unsafe or unwise. That is a competent person has the right to live at risk. But you need to identify the rights, the priorities, the needs, and the preferences of the older adult before you figure out what you need to do. So we are wanting to highlight the importance of taking the decision making, or the lead of the decision maker is the older adult. Some cases that might be the substitute decision maker, and they may involve their family in helping to decide what that is, but that comes from them. So you might be asking, how do you see the issue? What is important to you? And go from there. A collaborative approach is often effective. This might, like I mentioned, involve the family. It might involve other members of the team. But again, the older adults drive those decisions. The interventions might include, providing some education, specific referrals, suggesting supports for overwhelmed family, the caregivers in the family, maybe developing a safety plan with the older adults. And there are various categories of interventions that we discuss in the guideline. Well, what we want to emphasize here is that any response needs to be individualized and tailored to that particular situation. What I would like to recommend that you do is to kind of be prepared for addressing situations of abuse and neglect. One tip might be to start by determining what kinds of supports and resources are available that are in your area. So Appendix H in the guideline is a fillable resource list. So it gives you suggestions of where you can look. And that's one way that you might want to get started so that you can know some of the resources that you could use. Moving along to the last practice recommendation I'll highlight, and that's the importance of responding to abuse and neglect according to what the legal requirements and what your organization's policies and procedures are. A common theme in the research was that healthcare providers were really not clear on what their roles and responsibilities were, and they did not always know what the law was or even adhere to the law. So we recommend that you are very clear on what the laws are and what your roles and responsibilities are. So moving into education recommendations, we have 4 recommendations for education. Some are for undergraduate or student education before someone becomes a registered nurse, or for other fields as well. What may be unique or what may stand out for you here is the recommendation for all employees, that everyone in the healthcare organization receives some basic education, and that may or may not be happening in your healthcare setting. So this could be people like cleaning staff, dietary staff, administrators, that they all receive some basic education. And we're looking at things such as ageism or other factors that contribute to abuse and neglect, and any particular roles and responsibilities that people at different levels of the organization might have. The detailed education for nurses and other healthcare providers is a significant part of the guideline. We outline and describe several areas that we think the nurses and other people providing direct care need to be prepared to be effective in the field. So that is more detail about understanding the complexities of abuse and neglect, effective strategies for response behaviors, and what people can do for supporting a healthy work environment. So you may want to look at these education recommendations and see if there are any particular gaps in the education that is provided at your organization. Also, strong education programs will really help you be prepared to respond appropriately and help you to prevent and identify abuse and neglect. So we do recommend that education design is thoughtfully done, that education programs are engaging and interactive, and that they don't just raise awareness, but they address your attitudes and help build skills. Also, an interprofessional approach to education will help other team members learn together in a collaborative environment. So moving on to the policy, organization, and system recommendations. These focus on higher level support that help support the other recommendations in the guideline. So for example, we are recommending that organizations develop collaborative teams, and the makeup of the team would depend on the setting, but it may include individuals such as informal caregivers, police, faith healers, dentists. We stress the importance of organizations having clear policies and procedures. So if you have borrowed a policy from another healthcare organization, or you're using a decision tree from another sector, you need to make sure that those are compatible with the law and appropriate for your setting. Another important part of this section is that is looking at a multifaceted approach to preventing institutional abuse or abuse that might happen within a healthcare setting. And this addresses things such as staffing levels, training for responsive behaviors, screening and monitoring staff. Those of you who are working in organizations with health promotion and prevention mandates, we recommend that you are actually leading or participating actively in public awareness, looking at ways that you can address the factors that might make people vulnerable to abuse and neglect, such as social isolation that Elizabeth talked about, that you might be involved in supporting age-friendly approaches, or participating in a coordinated community response with other sectors and other groups that are interested in preventing and addressing abuse. The last 3 areas of recommendations for policy, organization, and system focus on, the first one I'm talking about is the regulatory bodies. And one of the challenges that we encountered when we were developing this guideline is that there is a lot of variability in what the laws and obligations are according to different sectors and across the country. And given that nursing regulatory bodies are responsible for public safety, we are recommending that they support nurses in providing accurate information so that they can uphold their responsibilities. In terms of government recommendations, we are acknowledging that it might be difficult to implement some of these recommendations if we don't have adequate support from government. So one recommendation outlines the government's role, and an example of what we highlight there is sufficient funding and human resources that is needed in the field. And lastly, we recognize that some of these recommendations may not be implemented without a bit of pressure. So we have outlined advocacy roles for nurses and other organizations, such as ourselves at RNAO, to support some of these changes that need to occur in various areas. So what is next? Now we have this best practice guideline, and you're probably wondering how we actually move this into making some real difference and making some change. So I'm going to outline what some of our implementation methodology, and I'll just give you an overview of this. One of the strengths of RNAO is that we really do have a systematic process for helping individuals such as yourself or groups or organizations move best practices into action. And we provide resources that are free to anyone, so please check out our website. It's www.rnao.ca. And we have things such as e-learning courses, fact sheets, this toolkit that's on the slide, the toolkit for implementation of best practice guidelines, we use extensively and encourage you to take a look at. We have training opportunities, champions, workshops, week-long institutes, and we also have the formal BPSO designation, and that helps organize that. We work with organizations to implement a number of BPGs, and they're supported along the way to maintain and evaluate the implementation of guidelines. And what I'd like to point out is that we're in the middle of working on some support for this guideline. So by the end of the fiscal year, we'll have an e-learning course. So keep an eye out for that. That will support the education recommendations. And we're also having a fact sheet and a condensed version of the guideline that will be available soon for upload on your smartphone. I'm nearing the end here, but I want to highlight some tips and suggestions for getting started. So here's what we suggest that you do is take a look at the guideline and identify some recommendations that you think will apply to you in your workplace. And do recognize areas where you think you are already doing some good work. And then highlight some areas where you think you would like to improve. And you might start by doing some small things that make a difference, like you could start by filling out parts of the resource list in the back that I mentioned earlier. Find others in your workplace or others other people in the interdisciplinary team who also care about this issue and work together with them. And look on our website. Look at some of the resources and supports that we have that can help you on your way. Just before questions, I wanted to put up a slide that names all of the expert panel members who contributed a great deal of voluntary time to develop this guideline, and also acknowledge there's not enough room on the slide for the whole RNAO team and all of the 60 stakeholder reviewers, but I just wanted to make sure that you could see the names of the people on our panel. I think we can open it up for questions and discussion. There will be a little bit of a pause before we move into this, but as we're waiting, you can look at or write down the contact information there. And my name again is Susan McNeil. You can email me or you can visit our website. So one of the questions is about mandatory reporting in Ontario. And there is mandatory reporting in, now I can't say that I know all the ins and outs of reporting for all of the sectors throughout Canada, but I am aware that there is mandatory reporting in the long-term care sector in Ontario. And actually, within Ontario, there are elaborate decision trees and procedures to follow for responding to abuse and neglect, and that's very explicit. The regulations are very clear and explicit for the long-term care sector. I don't think I can speak too much to other sectors about specific laws, but
no, and I think the challenge is that every province and jurisdiction has slightly different approaches in terms of these issues of mandatory reporting, and as something that Susan had mentioned before in our practice guidelines, it was recognizing why this isn't as straightforward as, if you will, as say something like child abuse, where we do know that if anybody comes into contact, that because children are not of age and therefore they can't consent, then there are more automatic and straightforward reporting requirements. I think the first lesson we learned as we looked through our practice recommendations was understanding that a patient may choose to live in a situation where they are being abused. And if they are capable of making that decision, then we have to respect their rights. But I think our guidelines and review of the evidence showed us as well that there are things that one can do to try and minimize or try and eliminate that situation from happening, and really focusing on the individual's quality of life. So we learned that it's quite complicated and why a thoughtful approach and practice needs to occur.
Okay, thank you, Samir. Another question has to do with cultural sensitivity, and has cultural sensitivity been considered when making this best practice guideline? And certainly it has. When it comes to culture, and maybe Samir or Elizabeth can speak more to this than me, issues become very complex. And so we do outline the need for cultural sensitivity training and for that to be considered when you're developing an individualized approach. And some of the background discussion in the guideline does address some of the complexities. Also, when we're looking at, throughout the guideline, issues of culture do come up. We don't have one particular guideline or one particular recommendation focused on culture, but it's integrated throughout. Anything that... Okay, so the next question is, can you tell me how the older person's capacity influences their decision to not call what looks like clear elder abuse to be abusive? Let me just think about what the question means. I'll start by addressing the issue of capacity, and we'll see if I'm addressing the question appropriately. But capacity definitely is a really important consideration. So as I discussed earlier, that when you're determining, you're making decisions that you want to take the lead from the older adult. And so I think sometimes what happens is there's an assumption that the older adult does not have the capacity, and that there's a deference automatically to a family member, perhaps, to make a decision. But capacity is a very important, if someone truly does not have capacity, then they are not in a position to maybe make decisions, and the substitute decision maker would be doing so on their behalf. But we do outline some considerations in the guidelines for capacity. The definition of capacity, how that is determined, does vary across the country, but it is a very important consideration, and I would suggest that you look at the discussion about capacity in the guideline that outlines some of the considerations for you.
I think some of the further consideration around this question is that, is the person capable? So when you think about examples of individuals who may have an advanced dementia, for example, where their capacity for decision-making, for understanding what's happening, may be affected, then those are situations when those who, are looking after them or now must make decisions on their behalf. Those are ones where it's hard for those individuals to be aware and puts them more vulnerable towards abusive situations. I think there are those individuals who are capable of making decisions, but they may not also recognize situations that are abusive, for example. And so I think this is how nuanced all of this can be, because I think one of our first pieces is, does the person even recognize, if they're capable, that abuse, what we would define as abuse, is occurring? How do they feel about that situation? Are there things we can do to prevent it? So that's why it's really important to have the therapeutic relationship, because sometimes even if a person is capable, they may not actually recognize what's happening. But I think the question then is, if they do understand and recognize what is happening, then how would they like us to address those issues? And I think that's where the importance of capacity comes into place.
Okay, and I think this question is kind of a follow-up question, and I think you've addressed some of this, is what is the nurse's responsibility to ascertain the older person's capacity? And what I can say is this varies according to where you're working, in terms of the laws and how capacity is determined does vary across the country. And so I can't give you a straight answer about that, but if it certainly is within the nurse's role, if there is a concern about possible capacity, that is brought forth and that is addressed.
And I think building on this, when we think about the care team, we're not trying to suggest to these guidelines that this is, if a nurse is concerned around an individual's capacity to understand the situation they're in, that it then becomes the responsibility of the nurse to do a capacity assessment. Capacity assessments are complicated. Often, they require different professionals to be a part of this aspect as well. And so, for example, our social work colleagues, our occupational therapy colleagues, other colleagues, physician colleagues as well. So I think the key is what we are trying to talk about with this guideline is how we've seen that an interprofessional response is usually a good one, so that if someone does, I think it's within the nurse's scope of practice. I think what we learned about and what we had our consensus around the room was that, if a nurse has concerns, it would be good to within their scope, to explore that further, to ask some further questions, to build on that therapeutic relationship, to gain more information. They may have some concerns around a person's capacity, and this is where sharing it with the other team members with permission, and therefore getting people involved would be helpful.
Thank you, Senator. I think we've just got coming to the end, and I don't see any further questions. So perhaps I'll turn it back to you, or Jean, for any final comments that you might have, and also just to close this webinar.
Well, thank you very much, and thank you, Susan, for your very informative aspect of the presentation and managing to all of you, the team there, managing all of the questions. My final comment really is that we need to remember that elder abuse happens in all kinds of situations. I think some of the questions might have related to maybe those extreme situations, but to me, one of the greatest ways to prevent elder abuse, which we need to remember consists not only of abuse but neglect, one of the greatest ways to prevent it is for all of us, in particular in healthcare, to be fully aware of what elder abuse and neglect are, and to be attuned to it happening anywhere at any time. So with that, I want to thank all of our presenters, Elizabeth, Samir, Susan. I want to thank Verity for her support in this webinar. I want to thank all of you on the call for demonstrating to us how important this issue is. And finally, to say an evaluation will be sent to each of you by email, and this recording will be available in our archives online, and you will receive information as to how to access it. So without further ado, I'll bid you all good day, and thank you again for joining us at Nurses in the Know at RNAO.